2. Hello, everyone. I am so excited to have you join us today with our very special guest, Dr. Stephen Kraus. Dr. Kraus and I have gotten to know each other for many, 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 many years, and I would like to say that it is because of him and his good friend, not Doctor, but Aaron Reynolds, is the reason we actually have this webinar series today. They had their own webinar series many years ago. I had no idea what I was doing, and it was because of the help of Dr. Kraus and Aaron that we have what we have today, because they were just very instrumental in walking me through this process and helping me out. And it really tells you a lot about the kind of person that Dr. Kraus is, and he is just knowledgeable, giving, has a heart and passion for this profession and helping this profession. Now, he is a doctor who graduated from Palmer College of Chiropractic in 1988. He has owned 18 chiropractic practices in his career, is the president and founder of Biomechanical, a technology company for chiropractic that's focused on digital x-ray solutions, and that's really what he's going to be talking about today. He has an amazing background in what he has done for this profession for many, many years, and I really do encourage you to click on the speaker bio tab and learn more about Dr. Kraus if you don't already know about him, because again, he is absolutely amazing. And if you haven't met him or seen him at an event, really make it a point that you do go to an event, go by the biokinemetrics booth, go sit in one of Dr. Kraus's classes when he is speaking. Take the time to get to know him, because when I tell you that this man has just an amazing head for business, a huge heart for this profession, you're really doing yourself a disservice if you don't take the opportunity to see him live and in person. Dr. Kraus, I'm going to go ahead and turn it over to you.
Well, fantastic. Thank you so much, Christy. Wow, I'm actually blushing. So it takes a lot to get me to blush, but I appreciate that introduction. And I also appreciate being here with ChiroHealthUSA. The platform that we're using today, I'm going to share some information with you to help not only your business be more profitable, but also to stop the pendulum that has swung too far to one side. We've got to bring the pendulum back to the center. And what we're going to talk about today is x-rays. The pendulum, in my opinion, has swung just a little too far, where commentary within colleges, commentary out in the profession, especially impacting our new practitioners, this discussion of should we or shouldn't we be taking x-rays and limiting our scope and utilization of that wonderful tool. I'm going to talk about some research studies that haven't been presented to the profession before that clearly talks about the need. In addition to that, we're going to talk about wearing our business hats. As doctors of chiropractic, the majority of you wear 3 or 4 different hats, from HR to clinician to business manager to entrepreneur. And it's important that when we're wearing a certain hat, we try to keep one hat on at a time and then remove it to make sound business decisions. So with that all said, I do need to make the disclaimer that, as Christy already mentioned, I am the president of a digital x-ray system, so I do need to disclose that to you. I'm also going to be sharing some other information, but I'm not here representing Medicare, the OIG, or HHS. I'm here simply representing ChiroSight, our digital x-ray software solution, as well as Biokinemetrics, our umbrella company that produces digital x-ray systems. So the questions we're going to cover today: which views are medically necessary to be taking in certain diagnostic cases? What are some of the HIPAA considerations? How do you justify medical necessity? And let's figure out how to maximize our imaging department so that we're productive, we're doing everything for the right reason, but at the same time we're also adding to the bottom line. And how do we use software technology inside our digital systems to get better patient compliance? So let's just kick it off with radiculopathy. Wonderful subject that we're all excited to dive into. But whether it's a cervical radiculopathy, whether it's a lumbar radiculopathy, anytime a patient is presenting with those kind of radiating symptoms, numbness, tingling, pain radiating into the extremities, those are indications not only do we take an A to P lateral view of the involved area, but we're also supposed to take oblique views because of potential compression. And we would back that up with orthopedic testing. So if we're finding in the cervical spine, for example, we've either got a foraminal compression, a Valsalva's, a Sperling's. If some of those tests are also evident, not only is it indicative of taking oblique views, but you're actually warranted in taking flexion-extension views, some motion studies. So besides your A to P open mouth, your AP lateral, oblique views, you could determine that flexion-extension, depending on what your orthopedic testing or neurological findings are. If the patient says, yes, when I flex my neck forward, I get more pain, you're certainly warranted in taking a flexion view. Is there instability of the spine? Is a vertebrae sliding upon flexion or extension, whereas in the neutral lateral view, it isn't sliding? And so perhaps when you take an oblique neutral view, the IVF foramen might not be compromised. But when you perform flexion and you can demonstrate a few millimeters of anterolisthesis or retrolisthesis, now you've demonstrated some instability, some ligamentous laxity, some compression that could occur in certain positions, not always in the neutral view. So these oblique views that we want to take and possible flexion extension views, along with our standard A to P and lateral views, let's say it's cervical radiculopathy. You see the code here that you could be using. This is not a coding seminar today. It's really the need for x-rays. But when you have that diagnostic code, all of those views up above are warranted. If it's a lower extremity case, let's take sciatica as the example. In addition to the oblique views and flexion extension, and I can't impress upon you enough, so many DCs do not use flexion extension views of the lumbar spine. Many of us for years take flexion extension of the cervical spine, but we don't necessarily do that in the lumbar spine. Again, if we've got radiculopathy, there's certainly warranted need for flexion extension when you do your range of motion testing. If forward flexion increases pain or makes the radiating pain perhaps go a little farther down, you're certainly warranted in doing that in addition to the oblique views. So let's talk a little bit about, I'm going to go over 3 studies with you today, 2 main studies and the third one's more about findings. So 2 killer studies that you need to be aware of has to do with the lumbar spine, and specifically degenerative changes, whether that's disc degeneration, whether it's joint involvement. It's the taking of flexion extension views that are warranted, and let's go over why. Because if the disc height, so if the lumbar disc height between the vertebrae is showing that there is significant thinning going on, and folks, I realize the study here is very small print. Later in this webinar presentation, if you are interested in receiving these studies, I'd be happy to email them to you. You'll just click yes in the survey question that you want them towards the end of the webinar here, and I'm happy to send you these studies. And this one was in the European Spine Journal back in 2011. So let's just go over the highlights of it. And the study, had over 447 patients involved, and what they did, they evaluated the disc height, and what they wanted to see was there instability, and there was a direct correlation that if the disc height was thinning or starting to degenerate, it specifically had to do with a forward slippage. And what they wanted to confirm in the study, and they utilized flexion extension views to see if there was some type of slippage, they could see if there was an anterior bone spur or if there was a vacuum phenomenon visible on X-ray in the disc, that if any one of those findings was present, the patient had a high correlation of increased degenerative changes going on. So if you start to see the formation of bone spur formation, and on flexion extension view, if there was some kind of slippage, a forward slippage of that vertebrae on the flexion view or the extension view, then it was a strong indicator that degenerative changes were going to develop. And you wouldn't know any of this unless you actually took the x-ray. So this commentary that's been going around in our profession about, oh, you have to have all of these various red flags present to take an x-ray. Some of those so-called guidelines aren't addressing long-term degenerative changes. I want everybody to be clear that some of those guidelines out there are focused solely on acute low back pain, not chronic low back pain. The entire Choose Wisely component was related to acute low back pain. And what we're talking about with these degenerative changes obviously is not acute. It's an accumulation over time of instability leading to wear and tear, leading to bone spur formation, leading to the disc being thinned down. And so the correlation was high. And what they showed was that in women, and especially in men over the age of 40, what they found was that the anterior vertebral edges had a bone spur, or if there was endplate sclerosis or any evidence of vacuum phenomenon, then this was going to result in disc height degeneration and instability of the spine. And if someone's going to have instability of the spine, our chiropractic adjustments, our recommendations for back strengthening is critically important. And if we don't take the lumbar views, including flexion extension, in addition to our AP lateral views, if we don't do that, then we're doing a disservice to our patient if it's a male over the age of 40 and women in general, adult women in general, had a significant correlation if there was any kind of instability evident. And you didn't need to have radiculopathy symptoms in this study. So let's talk a little bit about a separate study dealing with lumbar lordosis. So we all look at the cervical spine and we talk about reversed cervical curves. We look at the curvature, and we've all seen correlation that if somebody has a military neck or somebody has a reversal of the cervical curve, they often start developing bone spur formation at C5, C6, or the lower cervical spine because of that spinal biomechanical abnormality being present. Well, in the lumbar spine, this study demonstrated that if the lumbar lordosis was not between 65 and 68 degrees, if that lumbar lordosis was either hypolordotic or if it was a hyperlordosis, greater than 68 degrees, or if it was less than 65 degrees, this study showed that there was a definitive risk for degenerative changes to start developing. And the prior study, we just got done saying that instability often starts to result because of degenerative changes to the disc. So how do you know if your patient has a normal lumbar lordosis? Are you going to observe this with visual postural analysis, or are we going to take an x-ray to know? A mentor of mine years ago said this: to see is to know. To not see is to guess. And I'm suggesting to you we should not be guessing with the long-term wear and tear on our patients, where we all know that once these degenerative changes have developed in the spine and they're present, we can't reverse it. We can't go back. We all can replace our hearts and have a heart transplant surgery. If our kidney goes bad, we can replace the kidney. If the knee or hip goes bad, we can replace those joints with brand new metal joints. But when our spine gets degenerative changes, it's done with. There's no replacing anything. There's no success with so-called disc replacement. There's no option for the patient. And we, as chiropractors, if we're going to walk the talk and we're going to stand and hold ourselves out to be spine healthcare experts, then we have to know. We have to know what our patient lumbar lordosis is. We have to know if they're at risk for spinal instability. We have to know where they're at on the scale of degenerative changes, because studies show that there's a high correlation of chronic low back pain when it comes to these instability findings. So the correlation had to do with standing lordosis. I just want to make that clear. So one reason why some of the Choose Wisely studies talked solely about acute low back pain, one of the problems with older radiographic studies and medical-oriented radiographic studies is that the x-rays were obtained in a supine position. The patients were laying on a table when those x-rays were taken, and therefore there was no accurate lumbar lordosis analysis whatsoever. This study made sure that it was a standing lumbar lordosis, and the correlation in DJD was evident when they did a Cobb angle. They basically did a lumbosacral angle, and there's two different Cobb angles out there, folks. I'm not talking about the scoliosis Cobb angle. This is kind of the lumbosacral Cobb angle. And there was a definite relationship with the study, and they found that, again, if the lordosis was too great or if it was hypolordotic, then it would lead to degenerative changes there was a high correlation that they were going to get degenerative changes. And this was in the British Journal of Musculoskeletal Disorders. So here's what we got to do. We need to be taking A to P lateral lumbar views to assess the lumbar lordosis. And again, this study showed high correlation in females, adult females, and more so for men when they were over the age of 40. And when you measure the lumbar lordosis, how are you going to do that? Are you going to get the protractor out and put that up on film for those of you who have film, or are you going to use digital tools that can help you achieve this? So in general, let's just sum up some of these studies. I've got a quote here, a statement from the website of Johns Hopkins Medicine. And right on their website, you can go to it. It's at the bottom there, and I'll send you this if you want these studies as well. I'll give you this link as well. And it says reasons to take x-rays of the spine, neck, or back. And in Johns Hopkins Medicine, they're saying if there's evidence for fractures, broken bones, arthritis, DJD, spondylolisthesis, any kind of slippage, degeneration of the discs, DDD, tumors, abnormalities in the curvature of the spine, too much of a kyphosis, a potential scoliosis, flared scapula, or congenital abnormalities. If you suspect or have some concern that your technique might be impacted by any of those conditions, or even though a congenital abnormality may not impact the outcome, it may impact your adjusting technique that you've chosen. So Johns Hopkins also goes on to say there's many other reasons that the healthcare provider may recommend an x-ray of the spine, neck, or back. So it's really up to you, the practitioner. And Palmer College of Chiropractic, who I happen to be an alumni, I received a letter from them back in February from their from their chancellor. And they went on to say that they could not support the choose wisely components as it relates specifically to the x-ray findings. And essentially what they said, it's a decision that needs to be made by the doctor of chiropractic based on their own clinical decision making and their expectation to provide clinically relevant information from taking x-rays. So we all know every human being has their own unique fingerprint, if you will, of the spine. And that's why these are complex clinical decisions, and that's why it's better left to us to decide. Okay? It's beyond acute care for low back pain. We're talking about preventing long-term problems. And so getting somebody out of pain with a half a dozen adjustments, oh, you didn't need to take the x-ray for that. Well, I agree. We don't need to be taking x-rays on every single patient. I agree with that. We don't need to be taking x-rays on every episode of back pain. I agree with that. But if a patient has never had an x-ray, or it's been over 10 years, or they took the last x-ray was in their 40s and now they're 65, 20 years later, for crying out loud, folks, I would want to know what my spine looks like. I would want to know what's the status of wear and tear on my back, because I'm going to take it much more seriously when you, the doctor of chiropractic, give certain recommendations. Certainly, developing trust in a patient is extremely important, but when the patient knows that you know what their spine truly looks like and what the condition is, trust goes up. What we don't know is what's truly in the mind of the patient. When a patient is sitting there, are they wondering, how does he or she really know what's going on inside my body? How does this doctor really know that there's an alignment problem with my vertebrae? They're asking that question. They're just not telling you that they're asking that question in their own internal dialogue. So with digital, there's much more clarity, and radiation exposure using cesium panels now results in a 49% less radiation dose overall with patients, because you're not having to take retakes anymore, or it's extremely rare if you would ever have to take a retake. Because of the ability to deal with contrasting images, you're able to get more clarity when you do look at the spine using digital, because you can do the various gray scales that you just can't do with plain film. Now, a lot of diagnostic complications or missed diagnoses. Let's say you've been treating a patient for a couple of months and you made progress and you got their pain from a 7 down to a 3, but that 3 just continues on, and then you finally decide to take x-rays. And lo and behold, you have a spondylolisthesis at L5, the same vertebrae that you've been adjusting. Interesting. What if you've been adjusting that sacroiliac joint, and you've been, let's say you've chosen side posture or a drop maneuver, and you've been hammering away on that SI joint for a month, and just on the one side, it just wasn't really going. You weren't hearing that cavitation. You weren't feeling like you were getting any significant movement. And then, lo and behold, you discover, oh, there's a spatulated transverse process of L5, or there's a fusion evident. And then we might even discover bone spurs, degenerative changes. What if there's an old compression fracture that the patient had no idea about or forgot to tell you about, old trauma? So with all these various defects out there, again, all defects don't impact your adjustment. I understand that. But there's 3 different studies out there. One said 12%, one said 6%, a whole bunch of different ones. But if we kind of round it all together, about 10% of the population has some kind of a spinal bony defect evident on radiographs, whether it's ponticulus posticus, whether it's fusion, whether it's an extra vertebrae, extra rib, whatever it may be. if 10% has that anomaly, that anomaly may be impactful anatomically. It may be impactful biomechanically. In the condition, it may not. But again, if we're not imaging, we don't know. So this is just an example of a few. So the one example I gave with the transverse process of L5 fusing to the sacrum, that occurs in 3.5% of the people, for example. That might impact disc thinning because of that on L5. So that's why it's important in utilizing digital X-ray, you can create more efficiencies in your practice. Right now with plain film, here's what the studies currently show for the utilization inside the chiropractic profession. Right now, approximately 40% of the profession utilizes digital X-ray. Approximately 30% are still using plain film, and another 30% have no X-ray at all in their practice, and they refer out for their imaging studies. So that's kind of the landscape, and that was based on us making over 3,500 phone calls across the country, tabulating those results. So other components that are important when considering X-ray in the practice, every state board, and I used to be the chairman of the board of examiners for the state of Iowa and then served as a representative for the state of Iowa for FCLB when they had their annual meetings. And when you look at all of the licensing boards out there, all of the state boards have some language relative to radiology and X-rays. And if you take or order an X-ray, you're required to have a radiology report on file. And what I've been hearing lately from a lot of younger DCs, they're concerned about liability, about having liability of reading the X-ray. And just so we're clear, I've had conversations with two different malpractice carriers. Folks, you're liable whether you wrote the report or not. You're liable once you looked at the X-ray. So if you looked at the X-ray taken by another diagnostic center that you ordered, you're still liable for what's on there. Certainly, you might be distributing liability to a radiologist who read it for you, but you're still liable. So I think it's a silly argument to talk about liability. You're liable if you don't take an X-ray. Okay? It's certainly going to be thrown back at you. Why didn't you take an X-ray in certain cases if you missed something? So you're required by all state boards to have a RAD report. So one of the other items that we said we were going to cover today was differentiators and the business case. So now we're going to take our clinical hats off and we're going to put our business hats on, and we're going to just talk about, does it make sense? Because for some clinics, it does not make sense to invest in X-ray or digital X-ray in their practices. They might be semi-retired, they might be in a medical facility, and just down the hall they can order X-rays, and they don't want to do the investment, and their practices have only a certain volume of folks and they're no longer taking new patients. Or let's say they're pediatric only and they can refer out for those X-rays and they don't want to deal with that. So certainly different types of practices, where you're at in the stage of your practice cycle can impact, is it right for you or not? But I'm going to go over some financial formulas to help give you, I'm not going to give you advice, but I'm going to just give you things to think about to see if it makes business sense. Obviously, moving to DR gets rid of the costs that you have currently for film, chemicals, film jackets, the time to store them, the time to label them. You don't have to pay for the developer maintenance any longer, bringing x-ray guys in to clean it. You don't have to deal with the space for storage any longer. And then when it's time to give those x-rays to another provider, you don't have to ship them out. With digital, everything's electronic. You can do it in a HIPAA compliant manner, encrypted. You can send it through the PAC system, and it's just more professional and modern. So the business case from a patient's perspective. So let's look at it from a patient's point of view. Well, it's the convenience factor. When a patient goes to a spine care expert, most of them assume that the spine care expert that they're going to has the ability to look at their spine if you're going to be an expert. And whether you look at that from referring out, whether you look at that from taking it within your own practice, that's up to you. But patients have an expectation of getting the image, so you have to decide what's the convenience factor. It depends. Again, if you're in a medical facility that's down the hallway or across the street, great. If someone has to drive, 20 minutes to go to, because all you have is the local hospital, but then they got to make an appointment. You can't do it that day. You got to do it another day. Is this an inconvenience for the patient in their mind? How are they perceiving it? The other benefit of having it in the office is it's immediate. You've got it right now. You've got the clinical information you need. You can also use that as an educational tool. I know a lot of doctors, some friends of mine, they refer out. Some of them immediately pull in that image from the diagnostic center within before the patient even comes back for the next visit. They've got it up. They can show it to the patient and use it. Others don't bring them in at all to show the patient. They talk to the patient about it and show them the report and explain that they've looked at it. I think that's a mistake because I think we're missing an opportunity to educate our patients by showing them their spine. It can be used for trust, relationship building. Those are the real reasons. The side effect of all this, the x-ray department can be a revenue generator. It's not the reason to add x-ray. It's a side effect that happens. So let's go over some of those revenue examples for a moment. So let's say you're average practice and you're going to take x-rays on 3 patients a week, whether those are new patients, whether those are existing patients that have a new injury, whatever they are, it's 3 a week. And that would mean you're doing 12 a month. And let's say we're talking about 3 views on average. So let's say we're not taking advantage of those studies we went over earlier where you might need 4 or 6 views. Let's say you're just taking 3 views. The average around the country is a $72 collection for those 3 views. That's $864 a month. Then over the annual revenue collection, that's a little over 10 grand. Let's say you took 4 views on average. Well, that would be close to 13 grand annually. Let's say you're a little bit busier practice. Let's say you take x-rays on 5 patients a week. That's 20 patients a month. It's really probably 21, but it's 20 patients a month. And let's say we stay at that 3 views, $72. Well, that's $1,440 a month. Annually, that's 17 grand. Now, if you took 4 views and you collected $90 for those 4 views, you'd be collecting 21 grand annually. Now, folks, once you have digital, here's what we all have to remember. You no longer have the cost of maintenance, film, chemistry, cleaning, etc. So once you've got the system paid for, it's pretty much gravy train. So this is what a standard digital system might look like. You've got your usual tube and generator, and then you've got the sensor box, the digital sensor on the left that captures the digital image. So that's called a retrofit system. So let's say you keep your existing plain film tube and generator, and all you're going to do is change the bucky or wall stand that the patient stands up against, and you're going to change that to a digital retrofit. the cost of a retrofit is about $468 a month. Or let's say your tube and generator are so old, they're 45 years old, or let's say you're a new practitioner and you don't even have a X-ray old one to use for a retrofit. Well, a 5-year monthly lease on a brand new full-blown system, everything brand new, is $776. So if you do that, the return on investment, essentially you're paying for your system in less than 2 years. If you're doing a retrofit, it's possible, if you're one of the busier clinics seeing 5 X-rays, you can pay for that in 1 year. So all I'm trying to say to you folks is having digital in your practice allows you to send images to your patients in a HIPAA compliant manner on their smartphone, and now they can show their significant other, they can show their spouse those images to help reinforce some of the reasons why they're coming in for care. In addition, for those other providers that you are working with, co-managing the case, if that's the case, you can send your professional digital images to them. And for those of you who still are concerned about liability, you can still send those digital images directly to a radiologist. And there are new plans out there where radiologists won't bill the insurance company, won't bill the patient, they'll just bill you. You can set up a contract for a much more cost-efficient manner if you're going to send a certain number that the radiologist can rely on, and you're basically just paying them for a batch monthly fee to get it more consistent. And then you've got a radiologist who's kind of backing you up. And then you're not impacting the patient with another bill. The way they used to do this 20 years ago, I recall, I've been in practice for, 30 years, and I remember, 20 some years ago, there was radiology folks out there who had you mail the plain films, and then they turned around and billed the insurance company. It can cause doctor-patient relationship issues. My recommendation is work something out with the radiologist where they don't bill the insurance. You bill the full technical and professional component. You do your own report. You can, with digital software out there now, you can create a simple RAD report in 3 minutes with the automated template inside the software, and then you're basically doing a second opinion with the radiologist. Now you've got the radiologist doing an overread, if you will. Other considerations with X-ray, when you go digital, you do have to do data backup. For HIPAA compliance, we all know that our EHR records have to be backed up. Well, so do your digital X-rays. They need to be backed up, and you're required to do that, and they need to be backed up in a safe manner. There's even been discussion from 3 different experts. One expert said the off-site component of the backup should be at least 15 miles away from your practice. Another expert said 45, another one said 100. Obviously the 100-mile ones are worried about, nuclear fallout or something that would fry all electronics. Anyway, I could make a political comment, but I better not. Anyway, what I'm saying here is those are considerations that you need to make sure that your X-ray partner is taken care of for you. So let's just talk a little bit about those biomechanical measurements for a second, and then we'll get into answering some of the questions. When we deal with biomechanical measurements, there's a science behind it. And as chiropractors, we all know it's philosophy, it's art, it's science. And biomechanical measurements help patients better understand some of the things you're trying to do. I know this depends on your technique. Some techniques, such as Gonstead, use different line drawings. CBP uses other line drawings. Upper cervical specific techniques use even more line drawings. So what it comes down to is explaining your technique, explaining how biomechanics plays a role, whether you're functional medicine, whether you're biomechanical only, whether you're trying to do structural correction or whether you're just doing acute care or whether you're going to give them preventative care or you're going to start talking about maintenance so that certain biomechanical alterations don't worsen. Whatever it is your philosophy, your techniques are, your clinical outlook, seeing is believing. Patients need to know that you know. And now they're so much more trusting and confident in what you do. We did a survey of doctors out there who have digital x-ray, and using biomechanical line measurements like this, where you can create the one on the left in 7 seconds, you can create the one on the right in 28 seconds. It calculates all the numbers and measurements for you. You've got to do the clicks at the right spot, and the software kind of guides you to do that. So when you do those measurements, how does that impact patient compliance? Well, patient compliance is impacted, and we're going to go over the results of that survey in just a moment. I'm going to ask you 3 questions that I'd like you to respond to. And these 3 questions are about your current x-ray status. Do you have x-rays on site or do you refer out? Do you have DR digital? Do you have CR digital? Do you have plain film? But maybe you have a plain film system, but you no longer use it. But maybe you have plain film and you use it more than 50% of the time. And then what are your future plans? And then do you want me to send you the studies? So I'm going to send you the survey here. And if you wouldn't mind answering these questions, I'd appreciate it. And then we're going to go over the survey that we conducted nationally regarding how did biomechanical measurements impact patient compliance? How did it impact referrals? So I'll kind of wait here to let more of you fill out these questions. And while you're doing that, I will go ahead and take a look at some other questions that have come in. Somebody did ask a question regarding one of the Medicare quality measure programs and wanted to know if they had removed in 2018 the x-ray question. And folks, I used to lecture on that, but I'm not aware. I'm not sure about 2018 if they did or didn't, whether they're going to report that or not. The person here states that they didn't think it was a good measure. And I recall that one for meaningful use, whether you took a low back x-ray within the first 28 days of the acute care. And again, they're looking at the acute practice, acute situations. So it looks like we've getting most of these answered. I'll give you just 30 more seconds to answer those, and then we'll end the survey. Any folks, out of fairness to everybody, any questions regarding software or whatever, I don't know that I should answer those product related, just to say that there's all kinds of line drawings that it does for many different techniques. I would just recommend we just do a 15-minute demo for you one-on-one privately, and you can ask those questions privately. Okay, so we're going to go ahead and end the survey, and we'll kind of get back to the slides here. So what role did the ability to annotate patients' x-rays with line drawings play in patient compliance? So this is over 340 respondents. 68% said they experienced an increase in patient visits due to better compliance when they used line drawings in the reported findings. 24% said there was no change in patient compliance. 8% it was not applicable since they did not use line drawings or measurements at all. what percent of patients did you show x-rays with line drawings and measurements to the patient? So 56% said that they showed over 80% of their patients x-rays with line drawings on it. 16% said they showed over 60% of their patients. 12% said they showed over 20% of their patients. Another 12% said they didn't show any of their patients. 4% said they showed over 40% of their patients. So a little different, kind of in the middle there. It was either kind of, here's what it is, folks. You either did it or you kind of didn't do it. So it's either in your protocols, it's in your procedures that you're doing it, or it's not, and you're just probably doing it on severe cases, is what the study survey results kind of showed. In general, however, about 80% of those DC surveyed, just 79%, said that they have more patient referrals from those patients after explaining x-ray findings in general with the patient. So I'm not talking about line drawings here. We're talking about just showing the x-ray to the patient, that they got more referrals from those people than they did without an x-ray. I can't explain the reason for it. That's just what the doctor's perception and finding was. But I'd like to think it's a variety of reasons. And one of those reasons, I think, based on the Palmer-Gallup poll finding, was related to trust. When patients trust their doctor, obviously you're going to get more referrals. If you don't have the trust, confidence, and outcomes, you're probably not going to refer. The question is, there's a debate out there because, I consider myself a very objective person. I love studies. I love technology. I love matching up technology and studies and utilizing that in the practice. And I've been that way my whole career. That's why I'm kind of a software geek, where I love having some kind of analysis. But what I can share with you, from having bought and sold over 400 chiropractic clinics and owning 18 of my own clinics, and working with a lot of different employed doctors of chiropractic over the years, and I can tell you my experience, at least, in these various settings. When we had an x-ray on the patient and we went over those findings with the patient, not only, in my opinion, I don't have a study, but in my opinion, better outcomes, better compliance, better satisfaction occurred. Better follow-through of care occurred. That's an opinion. And when we survey 300 plus doctors and 4 out of 5 kind of say the same thing, I don't think it's a mistake. When you look at these other studies where then you have some academicians saying, well, there's no proof out there that having the x-ray improved the outcome. There's no proof. Well, it doesn't mean it didn't. It doesn't mean it didn't help. Nobody's constructed the proper study. All the studies were related to acute care. And that's why I'm saying to all of us, I thought we as chiropractors focused way beyond acute care. I thought we're supposed to focus on the wellness, long-term health of the patient. I'll share this with you because this is a truthful story on my own cervical spine C5, C6. Ever since I got more involved with software 10 years ago, I've been sitting at a desk way more than when I was standing up adjusting day in and day out. And I took x-rays on myself. I had x-rays obtained on myself every 4 or 5 years. Always. I wanted to know what my cervical curve was like. And I was thrilled. It was great. I'm 53, going on 54 years old now. And about 7 years ago, my x-rays were beautiful. Well, I now have moderate bone spur formation, degenerative changes on my C5, C6, and I'm pissed off at myself because I didn't do the necessary preventative exercises. Well, if a patient comes in to see you, or a family member for that matter, And you take, let's say over a course of 15 years, you never took any x-rays on them. And then you finally do because now they're having a different problem or more, whatever, and you found they got all this DJD. How much more impactful would it have been 15 years ago if we would have started seeing the mild spur formation and said, hey, look, Mr. Jones, or look, Bob, my cousin, we got a problem brewing here, and this problem is going to, there's a strong likelihood this spur and degenerative change is going to get worse unless you take corrective action. That corrective action may involve chiropractic adjustments. It may certainly involve certain range of motion exercises, preventative care, postural, ergonomic considerations. And you might say out there, guys and gals, you might say, well, I give those recommendations to everybody. I don't doubt that. But how serious does the patient take it from you? Because they're like, oh yeah, he or she's giving me this recommendation. But if they say, oh my gosh, I've got a bone spur starting here, this is for real, I need to do this, I think it's something serious that goes beyond acute guidelines. It's us walking the talk. Again, I'm not here advocating taking x-rays on every single patient. I'm just saying the pendulum has swung way too far to the wrong end. 15 years ago, a big push started saying, oh, chiropractors were overutilizing x-rays. We're taking x-rays on everybody. And there was a big push in the colleges 15 years ago to back that off. And I'm saying the pendulum has swung dramatically too far. We've gone overboard the wrong direction. We've got to get it back somewhere in the middle, and we are not there as a profession. And I know we are not there as a profession because I surveyed over 3,800 clinics, and a third of the profession doesn't even have an x-ray machine in their practice, yet we are a spine care expert. Okay, we refer out. I know the truth, and the truth is we're not referring out on a frequent basis unless that x-ray machine's down the hall. We're not taking x-rays at a clip that maybe we should because subconsciously we know the convenience factor is not there. We're not. I say better patient care can result with better imaging and measurements. I think we can handle our own rad reporting, and on those cases you have questions, send it to the radiologist. There's so much more benefits with clarity in our x-rays, and then when we do the biomechanical annotations, and you can do them so much faster now. I know it was a hassle in the pre-software era where we're all using our protractors, we're using our slide rule with our x-ray pencils. And I did all that too, and I know it was time consuming, but now it's so fast. I mean, it's seconds. And you stay patient compliant, you're protecting records, and you're a modern practice. And patients feel and expect we, their spine care expert, to be that modern chiropractic practitioner. So I'm going to go ahead and answer just a few more questions here that have come in. So let me take a stab at it here. What is the fee per view to charge? If we were doing a 5-view cervical and a 4 to 6 view lumbar, what would be a cash price for this? Well, I don't want to be right now. I guarantee you, Christy Hudson is probably cringing. She's scared of how I'm going to answer this. So I'm taking the safe road. I don't want to be accused of price fixing, so I'm not going to tell you what to charge. But there are different rules of thumb. So you can go look at, because you said cash, you want to know cash, but why not go find out what the fee schedule is from a buddy of yours who is on insurance? See what the fee schedule is. I'm not telling you to charge what the fee schedule is. I'm just saying, well, that's what insurance companies are paying. Take a look at that in your area. What do the Blues pay? Find out what Medicare pays medical doctors. Now, in our state, in Iowa, Medicaid does pay for x-rays. Matter of fact, they require an x-ray still, believe it or not. in many other states, Medicaid pays for x-rays. Find out what they charge. So what I'm saying to you is look at what fee schedules are, and usually you charge more than the fee schedule. I did, anyway. You can take a look at what colleagues are charging. Call them up. Hey, what do you charge for 2 views? And just kind of see what the area is, and you can kind of judge that. As you know, there are certain rules utilizing your CHIroHealthUSA plan and rules to follow if you're having a different fee schedule for cash or time of service. The example I gave you on that financial analysis a little bit ago was 3 views, $70. That was an example. 4 views, $90. So take a look at it that way. Can you take a moment to discuss DR versus CR for chiropractors? So direct digital, DR, I'm just going to give it to you real simple. DR is the digital x-ray where when you push the exposure button, that image is captured and visible on your x-ray computer, or your computer attached to the x-ray machine. It's visible in 5 to 10 seconds. It's right there. CR is also digital, but there are still cassettes involved. So, and it's a phosphorus plate. It's not cesium. So the patient is still having high x-ray exposure, whereas with DR, cesium plates, not gadolinium, but cesium plates in DR give you so much less radiation exposure. They're much more sensitive and better. But CR systems, you would have a cassette, a phosphorus plate cassette that you feed into a digital processor. It's not in a dark room. And just so you're aware of the stats, Medicare for medical practitioners is reducing payments on CR systems by 20%. They want you to have DR. Do not buy a CR system any longer. I used to own a CR system because it was much more economical 10 years ago. But now the price of DR has gone so far down. I'm sorry, I don't want to offend anybody, but you're foolish if you go out and buy a CR system today. Foolish. Do not do it. ASH restricts DCs to take x-rays. We have to get approval for the x-ray reimbursement for certain plans. What's your take on that? Should I refer a patient out even though I have to take an x-ray on site, even though I have x-ray on site? This is a convenience factor, but have the patient come back on another day and just take the x-rays is one option. The other option is check with your plan design and perhaps submit a letter saying, I want x-rays exempted from the plan. You don't pay for them or you need approval. I want to be able to charge cash to patients for x-ray. Now you'd have to get that signed off by ASH to do that. And I don't know that they're going to do that. But I agree, it's a discriminatory practice against chiropractors, especially in states that have insurance equality laws. Somebody needs to sue them, but that's a lot of money. We currently have a Supreme Court case going on here in the state of Iowa. We're suing Blue Cross Blue Shield for that. Right here, Blue Cross Blue Shield of North Carolina has plans to not cover x-rays if primary diagnosis is low back pain unless you have a trauma or a neoplasm. Does that make purchase of DR feasible? It still does because 2 PI cases a month makes your payment. 2 PI cases makes your payment. Still feasible. I'm approaching the maximum time. I got an alert here that says the presentation is scheduled to end in 1 minute. So I'm happy to answer other questions later. I think I better invite Christy Hudson back on to close up. But I appreciate everybody taking time today. I'll try to answer your questions when we send you the studies through email. Thank you very much.
Thank you so much, Dr. Kraus, and thank you to everyone who took time out of your very busy Tuesday to be a part of our webinar series. This week. If your question did not get answered, because I am monitoring that, I will make sure that those get sent to Dr. Kraus, along with a way to email you back to get those answers to you as quickly as possible. Just want to remind you, whether you've been in practice for 1 year or 3 years, 34 years, I believe, was Dr. Foxworth's anniversary this month. You are always going to be thinking to the future and what is my chiropractic practice worth, and planning for retirement, which I believe is you're never too soon for retirement to start thinking, not too soon for retirement, but thinking about retirement and into the future. Dr. Tom Nasila is going to be here next week to talk about that. And really encourage you, he's one of our most highly requested webinar presenters, and this is the most requested topic that we get every single year, which is why we present it twice a year. So if you have not heard Dr. Nasila speak on this topic before, I really encourage you to go ahead and register early because it will fill up fast. We will be taking a break for the 4th of July, and I hope all of you have plans to rest and relax because you do deserve it. And then we'll be picking right back up in the second week of July with Miss Brandy Brimhall from KMC University talking about documenting and coding for unproven investigational or experimental procedures. So thank you so much for being here today, and I look forward to seeing you next week, same time, same place. Have an amazing rest of your day and a fabulous week. Bye, everyone. Dr. Kraus?
Yes.